Thank you very much, Leona, and thank you very much for inviting me, and I'm really honored to be here, and it's my first time in Hong Kong. Hopefully it's not the last time. I'll definitely come back again, and it's been a really very well received, and thank you for your lovely hospitality and looking after me. So I thought I would give you a little bit of an update about what are we doing now with the Royal College of Obstetricians and Gynaecologists, and mainly looking at who are we and what do we do. Thank you. So just to give you an idea who we are now. So our president is Rani Tucker, and she's a urogynecologist. I gather your chief of service is urogynecologist, and I fear that the urogynecologists are taking over the world. Even in council, we have 35 council members, and I think 20 of them are urogynecologists. So I think you guys are definitely taking the rest of the world. You can see here my colleague Geeta Kumar. She is in charge of the clinical quality. That's where you get your green top guidelines, scientific impact papers. Asma Khalil is our Vice President for Academia and Strategy. I cover the global health, and I'm the Senior Vice President. Laura, she looks after the membership and workforce, and Ian looks after education, and that's mainly where we talk about the curriculum, the exams, and so on. So this is, if you haven't been to the new Royal College, so some of you may have been to the old college, which used to be at Regent's Park. We've moved 2 years ago at the kind of the start of the pandemic in 2020, actually just 2019, end of December 2019, we moved to this new building in Union Street, which is in, if you've been to London, near London Bridge Station, near Borough Market. And it's a very interesting building because it's an old school with a listed, which is a listed building. And there is a new building which used to be an office, and what we've done is we've joined them with a big atrium in the middle, and it's really lovely, modern, and I think it suits the new kind of generation, but also the area is very vibrant. What we also try to do with the new building is to try to create a women's health hub. So there's a lot of people who now actually rent some of our offices. So we have the Royal College of Midwives who are now with us. We also have Best Beginnings, Well-Being of Women, the Faculty of Sexual and Reproductive Health. So all of these big women's health institutes, they all now live with us in the same building. And I think that's really good, because if we want to collaborate, if we want to do things, rather than trying to email, you can just go next door and knock on the office. And so the college really mission is to improve women's healthcare across the world. And our aim is mainly to set standards. So that's what we're good at. So we're setting standards to improve women's healthcare and help with training and encourage the study and advance of science. And we have so many activities. So we have a membership, education, academia, clinical quality, global health and advocacy. And I'm going to take you through some of these kind of activities that we do. So we roughly have about now 18,000 members across the world. Roughly 50% are in the UK and Ireland, and 50% are overseas. We have been seeing members growth about 6% per annum. We also have something called the associate membership, which is people who are not members of the college, but they want to get some of the activities, accessibility to the college. And they could be obstetricians, they could be medical doctors, anesthetists, or medical students, any healthcare worker, and that we've seen a real growth of about 26%. And this is kind of the distribution. So if you see here, the UK has 9,000. The majority of our kind of overseas are in Asia, and that includes obviously Hong Kong. India is a big chunk as well. And you can see some of the countries which over the years we have started to lose slightly, mainly in Africa. And that's mainly because of, I think, the deterioration of the currencies in some of these countries. It becomes expensive for them to continue the membership. But also the good, I would say, emergence of colleges within South Africa, Western Africa, and they have now their own colleges. Sorry. I tried to get rid of this.
Yes. No, thank you.
Thank you. So I'm going to start with education. So I can see here a lot of young doctors here, so that's really might be quite important. So we've recently have revised our curriculum because what we wanted to do, we wanted to create our doctors to be ready to become consultants and take care of the women. And the question is for us, how do we develop that and how do we modernize ourselves with the needs of women these days? So we've done few changes. We realized, for example, that advanced labor ward, which used to be kind of a special interest module, now we've brought that back to become part of the core obstetrics and gynecology because complexity has become higher in obstetrics. And the same apply for acute gynecology and early pregnancy. It used to be specialist modules that you can do as an elective. Now it's come back as part of your core modules. The four specialties continue to be as they are, but what we've done, for example, with research, and I know Leon is here, she's a great researcher, and I thought, for example, we have now done it to be a SIP, which is the capabilities in practice, to be a proper SIP for research rather than being part of the other modules where people do specialist interest, because we recognize that people are not really doing it as serious. And I always use an example. If you do fetal maternal medicine, you probably end up doing 90% fetal medicine, 10% maternal medicine. So sometimes you need to look at things and see how we can improve that. And this is kind of what it looks like, what the healthcare professionals' expectations. So these are the SIPs that you go through, your training, how you become a healthcare professional, how you become a researcher and scholar educator, how you develop to become eventually a consultant with your clinical expertise, as well as champions for women's health. And that's when we start teaching things we didn't teach before, like advocacy, for example. And this is what we expect. I don't know how many years you have to do training here, for example, in Hong Kong, but 6. So we have 7 years, and you can see there that the first 2 years, which is FY1 and 2, then stage 1, where we expect you at the end of stage 2, you do your part 1, and then by stage 5, we expect you to have finished part 2 and specialist training part 2 and 3 before you do 6 and 7 at the end. Now, I have a personal view about this because I feel, because now you have what we call a run through. So you go in and you don't get interviewed again until you become a consultant. And I think I missed that bit. When I used to be an SHO, you have to do an interview to become a registrar, then interview to become a senior registrar, and then interview. It prepares you to become a consultant. That competition is part of life. It's like my kids at school when they used to be, I love the American way, because if you're number one, you're number one. But in the UK, if you're second or third, you get also a prize, well done, etc. I'm very competitive. So I feel that we probably need to do an interview here. Not everybody can become a laparoscopic surgeon. Not everybody can become a Leona Poon for fetal medicine. Not everyone becomes a urogynecologist. So you need to help people to do some of that specialist training, not sub-spec, but a little bit of kind of more specialized to become kind of ready. And this is what we really look at when we're looking at the training, and it's really quite important. I think gone the days when you know that you kind of see one, do one, teach one. I think nowadays everything has to be done properly to be signed off, and this is kind of the levels what we look at. Now, the RCOG is one of our important kind of work that we do at the college, the exams, and you can see here that, for example, in 2023 we had almost 10,000 candidates sat the exam across the world. Just November, I just got this is fresh off because this was just last week. I think you had the exam here, and we had almost 1,000 candidates sat part 3 just in November, which is amazing. So we're doing really well with the exams, and you can see here all the centers that we have, and we have a lot of examiners, and thank you very much for those who help with examination. And you can see here, have to be proud, Hong Kong is the 3rd after UK and India in the number of examiners in the world. So I think amazing, isn't it? 65. So really, really proud of you guys, and thank you very much for your help and support. It's really helpful to know how much you support us. Now we have a new system called the Learning Management System, the LMS, and that really gives you accessibility to a lot of new features and how you use education. So if you don't have that and you're not an MRCOG member, you can get that if you become an associate member. For a very small fee, you get a lot of accessibility to a lot of information. So I highly recommend it for you. These are the top 5 countries from outside the UK who access our LMS system. Now, we've done surveys recently and we recognize that we have a big problem with burnout. And I think it's important for us to mention this because our specialty is a tough specialty. You know, we're not histopathologists. We're not microbiologists. We're there, hot, absolutely takes on call 24/7, and we need to be clear about how we go through, how we react to trauma that we go through. Every single complications that we have that happens to us while we're practicing affects us. We're humans. And I think it's really important to look at some of the work that we've been doing with regard to that. So this is some work that was published by Tom Bourne a few years ago, just before COVID, and they wanted to look at the prevalence of burnout among doctors practicing obstetrics and gynecology. And they did a big survey among about almost 6,000 doctors. And what they have found is really interesting. They have found high levels of burnout, but not only that, they found that that actually affects your practice. You become more doing defensive practice, which is not good for the women, and it's not good for the practice, and it's not good for the doctor. And really, it's really important to acknowledge that. I don't know why that's not showing. Anyway, so we've had some other work that's been done, and basically what we have found that if you look at some of the, this is Andrew Weeks from Liverpool, and again they looked at that and they found that a lot of gynae doctors, almost 20% of them, will actually experience PTSD absolutely after their kind of complications. And not only that, but then that affected their work, increased sickness. And interesting, I know Andrew very well. He's a good friend of mine. And he had a presentation last week, which I tried to say it here. I don't know why it's not showing. But what he said, they have actually appointed within their department an in-house psychologist. And actually, that has made a big difference. Their actually sickness rate have gone down, being off, their production has gone up. And obviously everybody in that meeting was asking him, how did you manage to convince your managers to pay for that? So if we want to convince your boss there, you need to make the case of how this is going to improve our work. And I think there is clear evidence on what they presented. They haven't published it yet, but they have definitely shown improvement in work relationships, improvement in outcomes, and less sickness, and people are happier come to work. So I think there's a lot of work for us that we can learn from. And this is some of the kind of other works that some other people have done, and just showing again, obs and gynae, lots of evidence of PTSD, and that we need to have systems included. I don't know, sorry? Animation, yeah. So this is what we have as well. There's another trial by Rayburn, and they have found again, obs and gynae, job satisfaction problems, questioning career, lots of attrition problems we have in the UK. Lots of our juniors are leaving the profession at the end of their career, of their training, which is not a good thing. So what we have done as a college as a response, we have created a well-being resource hub. Please have a look at it. We have amazing things on it. Lots of direction of what to do, lots of organizations you can contact, lots of lots of apps that you can help. So it is something we take very, very seriously at the college. So this is what we've done with academia. So Asma leads on this. So we created something called a point of care ultrasound training, and that's to help people to be trained, to be ready in labor, to do simple tasks like is it head, is it breech, where the placenta is. We have now put in a new priority with the president, which is the maternity safety, because as you probably have seen from our Embrace reports that just recently came out in November, showing again we're not doing well. We're failing our women. Women are dying still from pulmonary embolism, still dying for postpartum hemorrhage, still dying from cardiac disease, and we're still missing a lot of patients and lots of things that we can do better, including how we have equitable care, because Black women are 3 times more likely to die, Asian women twice likely to die, and the babies of African or Black women of African or Caribbean origin, babies of Asian women, again, twice as likely to die compared to white women. And that's even if you allow for socioeconomic status, smoking, and all the other parameters. Still, just the ethnicity makes you more likely to die. And therefore, we should do better on that. Now, if we go to the quality, we now have something called the Tommy's app. The Tommy's app is a new clinical decision tool to use based on some of the work that has been done over the years by Professor Nicolaides, and I'm sure Leona will probably have been part of the work that they've done for that prediction of how, who develops preeclampsia, when we should deliver them. So Professor Baski Thalagam have taken that and put it in an app, and we are now trying to understand if this going to be something that people can use, especially in low income countries. So at the moment, we are trying to do some implementation in some of the UK hospitals and to see if it's going to be working well. Now, our green top guidelines are probably the one of the most important aspects of what we do in the quality work that we do at the college. And they're very highly thought of internationally. Interestingly, I'll give you a good story. Recently, I was visited by a doctor from Ethiopia who is not a member of the college, but after the meeting, we came by passing by one of the offices where we actually store a lot of the green top guidelines. And he actually stopped there and actually had tears in his eyes. And he said, I'm in the building where the green top guidelines come from. And he said to me that in Ethiopia, the green top guidelines is like the Bible for us. It's really important, although he doesn't know anything about the college apart from the green top guideline. So, so we have lots of new guidelines that has come out over the last few years and always coming out. Now, some people sometimes accuse us of delay because each guideline takes about 2 to 3 years. And there are reasons for that, because we have a very strict guidance of how we do it. We are the only Royal College in the country that has the approval of the NICE guidelines to use NICE stamp at the end of that guideline, because we do it in a very thorough way. So it's a very highly thought of, and we're very proud of what we bring out. One of the new things we've done now, we have lots of translation services within the website. We have to modernize. I think this is really important. So these are some of the languages that we now have for a lot of our guidelines that automatically you can translate. And we also started doing some animation, for example, for a patient to have a consent for a planned cesarean section, just to explain to our patients how things are done. Now, this is my portfolio. So global health and events. So I'm in charge of all the meetings, Congress, and global health. So here are some of the issues that we're facing. Every day, we know about 800 women die from causes related to pregnancy and childbirth, meaning that a woman dies every 2 minutes. So by the time I finish my talk, we'll probably have 30 women, unfortunately, would have died somewhere in the world. There's also about 2 million young women in Asia and sub-Saharan Africa are suffering from obstetric fistula. When I was a young doctor, obstetric fistula was quite big. Everywhere you go, people talk about it. But I feel ashamed that it actually, in the college in particular, but in other actually conferences and events that I go to, it seems to drop off the news. It's not sexy anymore to talk about obstetric fistula. Until recently, I went to a meeting called GLOW, which is the Global Health meeting in Glasgow a few months ago, and it was an important part of the discussion. And I feel that it's important for us to discuss it and start doing something about it. So I brought it back as one of our priorities for global health. 2 million young women are suffering from obstetric fistula. Another important problem we have is 60 million women want to avoid pregnancy, and they end up with having unsafe abortions with all the complications that comes with it. There are 200 million girls and women who today have gone through female genital mutilation or cutting. 200 million. This is 5% of all the female population in the world have been cut in their vaginas for nothing of their fault at all. So we are determined to make some changes. So we are prioritizing gynecological health. We aim to eradicate female genital cutting. We want to also mainstream abortion care and make it safe and improve our maternal health. So one of the important things is that I'm doing now is I'm trying to get all the leaders in the world and see how we can, with the next Congress in 2025, discuss and try to put implementation of how we can fight together obstetric fistula. The main reasons are delay getting pregnancy care and labor care. Some people think that cesarean section is harmful, so they wouldn't do it at all. And also timely access to obstetric care and delaying young age. So avoiding child marriage, because I think these young girls whose bodies are still growing end up with obstructed labor and end up with fistulas. One of the problems we have recognized recently that gynecology has been forgotten. So if you look at the WHO, if you look at the UN, lots of people talk about maternal health, maternal mortality, postpartum hemorrhage. But actually, apart from abortion, which is part gynecology, part obstetrics, gynecological care is completely forgotten. And nobody does much about it. So we feel that it's for us to try to bring it to the forefront. Problems with menopause, problems with cervical cancer, problem of access to contraception. So we created this something called training program called Gynecological Health Matters, where we actually teach basic gynecological skills to healthcare workers so they can do a smear, take proper history, and refer girls and women to the right medical setting for advice and management. And it sounds simple, but actually nobody else does it. And these are the 11 modules that we do. And interestingly, I was in Kolkata recently, and I went to visit the slums in India, and a place called with a group called Kolkata Rescue, which we felt that this would work. But the problem we have with some of the slums in some of the Asian and African countries, actually, they don't have nurses, actually have accessibility. And this was designed for junior doctors or nurses to develop and use. So what we are now doing, I decided to actually have like almost a Gynae Health Matters light. So to teach community health workers like the Aishas, who can then go and advise. So make it slightly less medical, less clinical, but still does the same. So therefore they have accessibility to the women we can't access. So watch the space, and I'm hoping by February, March, we'll have a new module that we can use in some of these countries, but doing the same aspect. So we've done that in Bangladesh very successfully, and we just got funding. We're now going to be doing it in Nigeria as well. Of course, maternal health is an issue. Women are still dying from postpartum hemorrhage and preeclampsia and infections and unsafe abortions. And we have done a lot of work with our Safe Abortion project. We had a 5-year project, £5 million over the last 5 years. We've done wonderful work with it. And if you look in our website now, we have a lot of training modules, advocacy modules that you can use and learn. I've also started the process of globalization of the guidelines. It just actually came by coincidence. I was speaking to Professor Andrew Weeks from Liverpool, and we've asked him to write a new guideline for postpartum hemorrhage. FIGO have asked him to write a new guideline for postpartum hemorrhage. the Asian sort of society have asked him to write a guideline on PPH. And he said, wouldn't it be wonderful, we just have one guideline? And I agreed. The problem we have with the Royal College guidelines, and that's why they're popular, because they're a very high quality best practice. But high quality best practice doesn't always translate into low income countries. So we need to have adaptability of these guidelines. So we're going to be using the global health, the postpartum hemorrhage guideline to have the first guideline with annexes at the end, where you have some adaptation of what you do in low income countries, what you do in middle income countries, and what you do in high income countries. For example, accessibility to carbetocin or syntocin, you don't have accessibility to all these drugs. But I think this particular guideline adapts well to make it a globalized guideline. Now we're going to be using that as our first kind of trial, and if that works, then we may be able to do it for other guidelines. And then maternal health, which is something I'm quite passionate about. But when I came to the college, our main project was the Safe Abortion Project. And that was at the end of the 5 years. And of course, we had to end up with lots of guidelines and templates and scientific impact papers, etc. But what that meant is that over the 5 years before, we did not have a lot of maternity projects. And now I'm trying to bring that back. We have small projects that are going around the world, which is our basic obstetric training, the BPS. We have something also the robust, which is the operative birth simulation. And they are well used in a lot of countries as franchise courses, where we train people how to have timely interventions, how to be able to experience all operative vaginal birth, and when to do a proper documentation. My colleague Shakila does a lot of work with us as well. She's from, used to be in Birmingham, now in Liverpool. And we have this new project called the C-Safe program. As you know, there is an ever rising cesarean section rate around the world. And one of the problems we have is that we don't really know why. So we try to identify the reasons, what makes people end up with high cesarean section rates, but also how we can make it safer. And this is mainly done in some African and Asian countries. So hopefully we'll report to you with the outcomes pretty soon. Now, this is an area that I'm really interested on. It is eradication of female genital mutilation. As I've said, more than 200 million girls and women today have gone through genital cutting, which is 5% of all female populations. And we are expecting another 70 million being at risk to be cut by 2030 if we don't do anything about it. It's a human rights violation, in my opinion. These girls have absolutely no say. They're just taken by their parents or grandparents or aunties or uncles, and they're being cut. It is considered violence against women and girls. And I think, this is my view, and a lot of people agree with that view, this is how society and men want to control women, because it's all about sexuality and child abuse. So that women should not enjoy sex. They should be cut, because that makes them less promiscuous, to be ready for the man when they get married. Some of these societies dictate. And medicalization has become a problem, almost legitimizing this process, because if you do it in a clinic by a doctor, it is safer. And what happened that we found with medicalization, the girls are getting younger and younger by age to have the process, because there is an assumption that you're taking them to a clinic, so it is safe to do. And this is the prevalence in some of these countries, mainly in the MENA region, but also a lot of African countries. I'm half Sudanese, half Egyptian. So this is where I live. I come from, between Egypt and Sudan, and they have the highest prevalence of female genital mutilation in the world. But interestingly, you find it in different places, in, for example, Malaysia, Indonesia. And it's not related to religion, because a lot of these countries are not necessarily related to Islam as some people expect. For example, Eritrea is mostly a Christian country, while if you go to the Gulf region, like Saudi Arabia, UAE, Qatar, and so on, they don't have FGM at all. So it's more of a tradition. And these are the types of female genital mutilation. So type 1, where the clitoris gets cut completely. This is what they call type 1. This is WHO classification. Type 2 is where they cut the clitoris and part of the vulva. Then the worst is type 3, which is both vulvae, labia minora, labia majora, and the clitoris are cut completely and stitched with a very small entrance. They normally stitch it around the matchstick. So therefore, when the man comes and have sex with his new bride, it is so narrow that he gets amazing enjoyment of sexuality. But she's gone completely. There's nothing there. And then type 4, which is anything that you can do other than the other 3. So some people argue some of the new surgeries that people do is what we call vaginal rejuvenation is a type 4 female genital mutilation. For example, in Malaysia, what they do, they take the babies at the age of 6 months and they prick the clitoris. It's a tradition. And they say only pricking the clitoris. But actually what happens that because that baby is only 6 months old, putting that small needle through that small clitoris actually damages a lot of the nerves. So when they're adults, there is no sensation in the clitoris. And not only that, they end up with scar tissue and complications. There are lots of publications. And that happens. If you've been to KL, there are actually adverts by clinics on the road for clinics advertising, bring your 6 months old baby so we can do this lovely tradition. But there are lots of complications that come with it. There are physical, obstetric, sexual, psychological. There are immediate and long-term. And a lot of these kids sometimes die because of bleeding, or they end up with hemorrhagic shock or infections. They end up with fear of sexual intercourse, vaginismus, long-term complications, abscesses, and of course, the psychological trauma that these children go through, they will never recover, never ever recover. And medicalization has become a problem, although female genital mutilation, thankfully, is getting less, but actually the prevalence of medicalization is getting up. So what I have decided to do is that, how do we combat that? And we developed a toolkit mainly targeting Egypt and Sudan, but because of the war in Sudan, we're now concentrating the work mainly in Egypt, is how we then equip these doctors. Because in Egypt, 85% of medicalization is done by doctors. While if you look in Sudan, 85% are done by what we call traditional birth attendants. So kind of non-clinical midwives, if you like. But it's a source of income for them. And that's why they do it. So what we did is to try to have a training module that helps these doctors to understand how and why that should not be done. And we teach them ethics, we teach them the complications. And some of them, they don't even know the complications. And this is the aim of the workshop toolkit. It's an all-day workshop. So we equip them with the essential knowledge about, we also make them recognize the harms and complications of FGM, understand its legal human rights and consequences. So in Egypt, it's illegal, but people still do it. And then how they advocate for its abandonment in the community. How they stand up to their bosses who do it in their private clinics. If you're a junior doctor, how you tell them we need to equip them with that. One of our more important work that we work is advocacy for greater sexual reproductive health rights globally. Unfortunately, if you look at a lot of countries now, they have reduced their funding for sexual reproductive health rights. And I worry even more with what's going to happen in the US with President Trump. So this is going to be, the Americans are big donors when it comes to research. The UK has halved its funding for sexual reproductive health. because of all the issues that we have in the country with the Ukraine war, with the other kind of problems that we have financially. So it is a threat to try to get money to fund research and advocacy. And that's what we do. We do that at local level, we do that at international level. When I took office, I found that we have this something called RCOG status. And nobody knew at the college what it is, but we have this status. Everybody's proud of it, but nobody knows what it is. And then I discovered that this is basically, you have a chair at the top table at the UN where you discuss economic, social, sexual, reproductive health rights of women. And actually, I don't know how we got it, but somebody applied for it, they did a lot of work, and that person has left the college now, but nobody was doing anything about it, apart from being proud to have the title. So what we're doing now is try to understand how we use our status, what does it mean for the college, and how actually we make use of that seat on the top table to advocate for women's health rights. I'm very passionate about training, and luckily I have the Global Health Trainees Committee at the Royal College, and I think young people, and I see a lot of young people here, are more concerned about global health than actually older people, which I think is a good thing. There's a more conscious with our young doctors. And what we have, unfortunately, in the UK now is that if you want to do global health training, you have to come out of program to do that. If you want to do subspecialist training with Professor Nicolaides, you can apply for it, but it doesn't exist for global health. You have to come out of program. It's not going to be counted towards your years of training. So what I'm trying to do before I finish my 3 years tenure at the college, which is December next year, is that I would have had at least 3 recognized training health modules that people can apply to, which will be part of their training. And I'm working with the global health trainees, so therefore they can do it. If you want to do global health research, if you want to actually go somewhere in Africa that you want to work, if you want to do some different type of work about advocacy. So we have different models which we're discussing at the moment, but I'm working with the trainees trying to develop this. And we have a fantastic, this is our committee there who I work with, and we're hoping that, as I've said, to finish it off by next year, we have the training modules already. A lot of you probably have attended some of our webinars, some of our courses. I should plug that next week on Wednesday, the 27th, we have a fantastic free webinar from the college, which is on uterine transplant by the leading team from the UK, Professor Richard Smith. That will be at 6:30 p.m. UK time. So that's a free webinar. If you register and if you can't attend because it's very late here, you will get it the next day. You can watch it at your own time. So please register. One of the things I have discovered when I came to the college is that we do about 50 events. Some of them are done 2, 3, 4 times a year. So we do about 120, 130 events a year. And it's a major kind of work for the college. But some of these events and courses have not been revised or updated for over 10 years. So I went through all of them with my colleague, Mr. Ian Scudamore, Education VP, and some other doctors we have chosen to help us, and the co-conveners of the events. We answered over 20,000 questions that we have put, remarks, comments, feedback, and we decided at the end to axe 4 courses. Some people were not happy with me, I can tell you that. Another 3 courses, we've asked them to update or be axed. And then the others, we've asked them to think about how we can become more global, i.e., can we do it as a hybrid? Can people in Hong Kong attend this course? Because we're a global college. 50% of our members are abroad. And I'm hoping that 2025, you will see new events are coming in. So we've asked people to bring new ideas. So we have new human factors. We're going to have a new genomics. We're going to have new things that are important for us, how we develop. So watch the space. The RCOG Congress, and I'm grateful to Leona who joined us in Muscat. That was on between 15th and 17th of October, 2024, so just last month. And this was a delayed one from 2020 because we were supposed to do it in March 2020. And that, because of the COVID, we delayed it. Unfortunately, we were also supposed to be doing one in Hong Kong, but that got delayed. So everything got muddled up. But we managed to go back to Muscat because we had some money frozen because of the COVID. Luckily, despite the airspace situation with the political situation in the region, we ended up with 2,200 delegates. One of the most successful congresses we've ever had abroad. The program was amazing, was very successful. I'm grateful for all of you who have contributed with abstracts with your presence. Next one is going to be in London, 23rd to 25th of June. It's going to be in Excel. Please apply your abstracts. I know a lot of research goes in this university. Closing days is the 20th of January, so please get ready. And I'm hoping that we're going to host you there, and please join us. If you have any thoughts of any ideas of any particular talks, because one of the reasons I feel that the one we had in Muscat was very successful, because it was very global. We had amazing information. Historically, people used to say information goes from north the globe down to the south of the globe. Definitely in Muscat, things were moving freely between all regions, and because a lot of good work done in different countries. The college relies on its volunteers. A lot of this work is actually done by our members and fellows, unpaid. Can you believe that? I can't think of any other organization can do such amount of work just for doing that and don't get paid for it, because people are proud of their college. Last year we had over 2,400 volunteers help with the work at the college. Those who do the exams, those who set up the exams, those who write the guidelines or referee the guidelines, referee the abstracts, do all the other work that we do committee work, come to courses, help with this. So we rely on you really much, and we're very, very grateful for the work that you do, whether you're an examiner, you're an international representative committee, or you're an honorary fellow. So please do help us and continue to help us, and we're very grateful. And this will take you, how you get involved, this QR code will take you to there. And on this note, thank you very much.